As we commemorate the World Haemophilia Day, we want to thank you for joining us as we engage in learning about hemophilia. And the theme for this year is for all and prevention of bleeds and a global standard of care. So I want to welcome our panelists today. We have Sister Marilyn Magai, our in charge at the Haemophilia Clinic and works with us at the Kenyatta National Hospital. We also have Sister Violet Atonya, who is also a senior nurse and works at the Haemophilia Clinic, Kenyatta National Hospital. These are specialized nurses trained to manage, diagnose, and treat hemophilia. And today we are going to start with Sister Violet Atonya, and she's going to take us through the genetics of hemophilia. Thank you so much.
Thank you, Dr. Gidinji. My name is Violet Atonya, as you have heard. I work at Haemophilia Clinic, ANH. I'm going to take you through what is hemophilia, the types of hemophilia, and levels and severity of hemophilia, genetic and manifestations of the disease. This condition is being mismanaged always in most of the county hospitals, and we get many patients being done surgery because of hemophilia. And we have actually thought of sensitizing about the hemophilia. So what is hemophilia? Hemophilia is an X-linked congenital bleeding disorder caused by deficiency in coagulation or clotting factors. That is factor 8, which is hemophilia A, and factor 9, which is hemophilia B. X-linked faulty gene on the X chromosome and gene changes. It's a congenital, that's it's inherited, you get from parents. Patients, most of our patients are male, while women are carriers of the disease. That's, as we know, male have XY and female have XX. So types, we have two main types of hemophilia. We have hemophilia A, it's also called classic. We have hemophilia B, which is Christmas disease or royal disease. It's called Christmas because the first person who gave birth to hemophilia kids was called Christmas. And they intermarried royal people and the disease spread. So hemophilia A is also called as a classic, or it's a factor 8 deficiency. It's a genetic disorder caused by missing factor 8 or clotting protein. So when you miss a clotting factor 8, you get hemophilia A. Hemophilia A is more common than hemophilia B. You get 80% to 85 patients who have hemophilia A than those who have hemophilia B. In setups without factor 8, patients are given cryoprecipitate or fresh frozen plasma, that is FFP. So nowadays, before factor came, patients were getting cryoprecipitate. They were to be admitted, they get cryoprecipitate, then they went home. But nowadays we have factor, and those who have hemophilia A get factor 8 as their drug. Hemophilia B, it's also called factor 9 deficiency or Christmas or royal disease. It's a genetic disorder caused by missing or defective factor 9, a clotting protein. Hemophilia B is less common, not like hemophilia A. We have 20 to 25 of hemophilia patients they are fewer compared to Haemophilia A or factor 8 deficiency. In times when there is no factor, fresh frozen plasma has high content of factor 9, and that's what was being given before factor 9 was brought to our country. Levels and severity of haemophilia. Haemophilia patients, when they come, the blood is withdrawn and it's taken to the lab. They do the severity, and the clinical manifestation of bleeding in haemophilia depends on the severity of the disease, which varies from mild, severe, according to circulating clotting factors in the plasma. So severity is detected in the lab. So we have severe, moderate, and mild. So in severe, here the functional plasma levels are less than 1% of the normal, and patients suffer from spontaneous bleeding even in the absence of trauma. A patient can just bleed when seated, or they sleep. In the morning, you find they have bled, maybe in the joints, the muscles, head injuries. Factor replacement is needed several times. So these patients who have severe haemophilia, they usually come to the hospital oftenly and to get the factor replacement. Bleeding tendency appears early in childhood. This is when the kids start crawling. Once they fall, or when they start teething, it's when now you realize they start bleeding. And when they come to the hospital, when you take samples for haemophilia, for coagulation, you find the APTT is raised, and you get they have haemophilia. 15 to 20% of these patients get antibodies to the therapeutic and prophylactic factor replacement. They usually get inhibitors because of the severity and frequent factor infusions. Moderate, their factor levels is between 1 to 5%, and it's less frequent bleeding. They have less frequent bleeding episodes. Bleeding usually follows trauma or surgery or dental works, especially when the kids are starting now to remove their teeth, is when you realize they have haemophilia, they bleed a lot. So these patients require to come to the hospital for factor before they are removed, before they see the dentist. Or when they have a trauma, just a small trauma, they bleed. So those are the moderate bleeders. And we have the mild. Mild is between 6 to 25 factor level in circulation in plasma. Bleeding happens occasionally, and usually it's after severe trauma or surgery. These patients can go up to even 20 years before they are discovered, because they don't usually bleed unless they have a severe trauma or they have been exposed to surgery. Is when they bleed a lot, but they don't come to clinics oftenly. A normal range for a normal person, it's 50 to 150 factor levels in the plasma. This table just summarizes the normal person has 50 to 150 factor activity, no percentage, no bleeding. Severe, they have less than 1%, and the percentage of cases are 60. So it's most of the haemophilia patients are more than, those who have severe are more than those who have moderate and mild. And it's spontaneous, they just bleed without even being exposed to trauma. Moderate, it's between 1 to 5%, and percentage of cases is 15%. It's lesser than the severe ones. And when exposed to mild trauma is when they bleed. Mild, it's between 5 to 25. There are 25% cases. When exposed to major or surgery is when you realize they're hemophilic. Epidemiology of hemophilia. The disease affects about 1 out of 10,000 persons. So in every 10,000 people, you get 1 person has hemophilia. In a global population of 7.7 billion, the whole world, there is estimated to be about 770,000 people living with hemophilia. In Africa, we have like 1.426 billion, and expected hemophilia patients are about 142,600. But in Kenya, we have a population of 55 million, of which we expect to be having 5,520. But of late, we have just gotten 650 people living with hemophilia. That's only 12% of the population. So other patients are still being unrecognized. They're still being unknown. So this sensitization actually is to make people aware of the disease and how we can get all of them not to suffer just outside there, and there is factor in the hospitals. So genetics, hemophilia is usually inherited through X chromosomes, as I said. It's a gene mutation of factor 8 or 9. 70% of all cases result from spontaneous genetic variants. It's inherited from parents to children to grandchildren. Hemophilia usually affects males who inherit affected maternal X chromosome. As we know, male only give the boy child the Y chromosome. So that's why they get the affected X chromosome from their mother. Females with hemophilia are rare because females have 2 X. So when one is affected, at least the other one will work. A female with 1 affected X chromosome is called a carrier of hemophilia. Carriers are asymptomatic or are rarely affected, though we get some of them when they're giving birth. Some have heavy menses. So let's see if when we have a father who is hemophilic, when we have a father who is hemophilic and the mother is not a carrier, the mother is okay, it's normal, she's normal. We get 0 chance sons who have hemophilia because of the Y they have received from the father. And we get 100 chance daughters who are carriers because they have taken the X from the father, and all girls, 100% of them will get hemophilia. They will be carriers because they have 1 X which is affected. When the mother is a carrier, we get 50% chance sons will have hemophilia, and we have 50 chance daughters who will be carriers. when the father and the mother are both, when the mother is a carrier and the father is hemophilic, we get 50% chance sons will have hemophilia because they have taken the X from the mother. So 50% of the sons will be hemophilic, 50% daughters will be carriers, and 50% daughters will have hemophilia because they have taken X from the mother and X, the affected X from the mother and the affected X from the father, and they become now hemophilic. But we have never gotten girls who are who have hemophilia yet. So causes of hemophilia is inherited. 30% of people with hemophilia have no family history of disorder. It's acquired. 70% is caused by genetic changes, spontaneous mutation on the clotting protein. So those that get acquired, they get from when they have infections, when they have been exposed to some drugs, when they have been exposed to surgery, they get acquired, but it's rarely manifested. That's all. Thank you.
Thank you very much, Sister Violet, for that very educative session. So I hope you've all learned at least a bit about the genetics, the background of how a patient acquires hemophilia, whether A or B. So next, to our next presentation, Marilyn, kindly take us through the next session.
Good afternoon. Good afternoon once again. My name is Marilyn Argai. I'm the assistant chief nurse at the Haemophilia clinic, where we work with Dr. Givenji, with Victoria and Rose. You're welcome to today's World Haemophilia Day. Today we thought it wise to sensitize the viewers. So we are going to go through our teaching today, and we're going to start with the clotting in hemophilia. That is just about coagulation. So in hemophilia, we've already been told that hemophilia is a rare disorder where blood doesn't clot normally. That is in the typical way, because we don't have enough clotting factors in the blood of this person. So coagulation is that process of making blood, making a blood clot. And this is usually a very important complex process that enables the blood to plug and heal a wound. So the body is able to stop any unwanted healing. So coagulation usually involves cells, and it also involves clotting factors. And the cells are usually the platelets, and the clotting factors are what we are calling the coagulation factors. So usually there is hemostasis, which is just the process of stopping bleeding and preventing damaged vessels from being lost. So coagulation usually is an essential part when we are doing this hemostasis. So in hemostasis, the platelets and the protein usually come together and they make a plug at the damaged blood vessel. So when a vessel is damaged, like what you are seeing here, this is the normal. This side where you're seeing, it is the normal coagulation taking place. When the endothelium is damaged, the lining of the blood vessels, there is some leakage of blood. So platelets usually come immediately and form a plug at the site of the injury. So at the same time, we have these proteins, which we are calling the coagulation factors. They normally respond. They are in the blood plasma. They respond and they come and form fibrin strands. So as the platelets are gathering together, at the site of injury, and the coagulation factors are coming, they undergo some series of reactions such that this plug is strengthened. But in the case of hemophilia, these factors are usually so weak because this patient doesn't have clotting factors like what you're seeing in this picture here. So in hemophilia, like we have said, the factor is defective. So the cascade, the one that I've just mentioned, is usually interrupted. Therefore, a stable clot is not formed, and instead of healing, there's breakdown before it heals. So we are going to look at the clinical features. So we've already been told hemophilia is an inherited bleeding disorder, which is characterized by bleeding tendencies. So the features are usually bleeding in the areas that we are going to look at. So these are some of the signs and symptoms that we are going to see. There's bleeding. It could be spontaneous bleeding. There could be dizziness if the bleeding is in the head, or headache. This person could present with a nosebleed or maybe swollen joints. So we have some types of bleed, and we've grouped this into two groups. We have major bleeds and then minor bleeds. So the major bleeds are usually life-threatening because they may cause deformity. And the areas that are usually associated with major bleeds include the central nervous system. We have the gastrointestinal tract, we have the leg, the throat, we have the hip or the iliopsoas, we have the advanced joint muscles, and then we have compartment syndrome, also in severe injury. In the minor bleeds, these ones are not so life-threatening. They do not impose any immediate danger to this person. However, if they are prolonged, it may cause complications, so it needs to be treated very early. And this includes the joint where we have hemarthrosis, the muscle or the soft tissue, we have the oral bleeds, we have epistaxis, and then we have painless hematuria. So we will look at the different areas, like I've mentioned, where we can get these bleeds. We have the joint bleed. This is one of the areas where blood can flow in. We have joint bleed, which is also called hemarthrosis. Usually, this is the most common presentation in most of our patients. Joint bleeds usually occur in the knees, in the elbows, in the ankles or the hips, but it may occur in any other joint. So the first symptom that these patients normally have is an aura, a tingling or some tightness in the joint. Some usually even come with that tingling and tell us that they are feeling some tightness in the joint. They know that they are going to have a bleed in this joint. So after one or several hemarthrosis that is bleeding to that joint, this joint is usually become targeted for recurrent bleeding, and is usually called a target joint. You'll hear us mention target joint. So a target joint is that joint that has been targeted for recurrent bleeding. So these are some of the clinical features that you'll see in joint bleeds. We've already mentioned the tingling that this patient may come with. There will be pain. This is what you'll see. The limb will look like that. And it will be warm. It will be tender. There will be swelling, like what you're seeing in the limb of this young man. There's also limited use of this affected limb. This patient is not able to use this limb because of the pain, and the range of motion is also reduced. They are not able to walk with this limb because also it is stiff, and also because of the muscle tightness. And at times, there are places where patients go with such a condition, such features in these periphery hospitals, and they are taken to surgery before they know that this patient has hemophilia, and we really get bad outcomes in such cases. So the other areas where we get bleeds is in the muscles. I'll just mention a few areas. So we look at the muscles. The muscle bleeds is whereby we have bleeding into the muscles, which is also known as the soft tissue bleeding. So bleeding within confined muscles, such as the forearm, usually causes compartment syndrome. And this is just a very painful condition whereby there is pressure within the muscle, which builds to dangerous levels, and this can destroy the nerves and the tissues. That's why we require immediate and high specific treatment for these patients so that we control bleeding. And in compartment syndrome, we have these 5 P's, which is pain, we have pallor, we have paresthesia, there is no pulse or it is faint, and then paralysis, that is, this patient is not able to make use of the limb that is affected. So the other side, the common sites or whereby bleeds can go, that is into the muscles. We have the upper arm, like we are seeing in this photo here. We have the forearm, we have the thigh, and we also have the calf. For toddlers, the babies who are still very young frequently have bleeds in the buttocks and the groin. And patients with low abdominal pain, those who come presenting, saying that they have a low abdominal pain and they're hemophilic, they have groin pain, probably this patient have a lot of psoas bleed, and maybe they are not able even to extend that foot because they have a lot of pain. And then there's also spontaneous flexion of this affected limb. Then this patient is having psoas bleed. So let's look at the oral bleed, the mucosal bleeding, where we have the dental, it could be in the gums, maybe there's lacerations in the tongue. And for young babies, the children who are between 6 months to 1 year, the early presentation that we normally see for these babies is when the tooth is erupting. When the tooth is erupting, that's when you'll notice that this patient is having oral bleeding. And when they have, they may come present to us with oral bleeding, and maybe the mother doesn't even know this patient is hemophilic until we do the coagulation profile, is when we come to know that this patient is hemophilic. The other types is tonsillectomy, uveilectomy. During tooth extractions, you'll have bleeding. We also have tongue laceration and frenulum. This one usually occurs to young children, whereby they fall with the face and mostly present at the clinic with some slow oozing, which is persistent mucosal bleed. Sometimes the area of the wound will have a dark black clot, which we normally educate these mothers not to remove it until they come to us, so that we give factor before we remove it. We pack it with maybe tranexamic acid. So we'll also look at the other areas, which is the GI and the genitourinary bleeds. So in the genitourinary bleeds, we may have spontaneous, persistent, or recurrent hematuria, which is mostly a painless hematuria. When these patients present to us, they come at times with abdominal pain and flank pain, and at times they have frank hematuria. They tell you that kuna damu kwa makojo. That's what they tell us, and we definitely know that it is the genitourinary bleed that has occurred. And it could have been caused by trauma, maybe kidney stones, spontaneous hematuria at times when a patient has undergone stenting. And the other areas where we have bleeds is the gastrointestinal bleeds. We have spontaneous, there's spontaneous onset, or usually precipitated by infection or direct injury to the gut. This patient, when they come to you, they will present with frank hematemesis and even with coffee ground vomiters. Some will come with hematochezia, whereby this is just frank blood that they fast with or without stool. At times they come with complaints of melena, and this melena usually is because of use of NSAIDs, the nonsteroidal anti-inflammatory drugs, then chronic alcohol intake, and then because of duodenal or gastric ulcers. The other area is the nosebleed, which is called epistaxis. This is bleeding from the nose. This can either be spontaneous, and at times it is usually induced by nose picking. You know, children, they can decide to pick their nose maybe.
Apologies for that small hitch. We are working on it. I think it's a power outage, but we'll be back in a few.
So we continue from where we left. Epistaxis is one of the areas that these patients come with, and this we say is bleeding from the nose. And this can either be spontaneous or induced by nose picking or trauma. And we were saying that our little boys and girls usually pick their noses, and at times it may trigger this bleeding. So when you're doing, when a patient comes to you and reports, they may not come in nose bleeding, but they may come and report to you that they've had nose bleeding. You should do a thorough history, you should take a good history, and these are some of the things that you should look at when you're asking this patient. You'll ask them about the length of the nosebleed, the length in minutes that the nosebleed took. You also ask about the approximate amount that was lost at that time that they had the nosebleed. You should also ask about how often they've been getting this nosebleed. It could be frequent, it may not be frequent. You should also take note of that. And then you should also know whether the nosebleed, the nostril, whether both the nostrils were involved or not, so that you're able to take notes and then you manage accordingly. The other area that we usually have bleeds is in the peritoneal, is a peritoneum, that is the peritoneal bleeds. This is whereby there is an accumulation of blood in the retroperitoneal space. And this is usually divided into three zones. This is zone 1, zone 2, and then zone 3. Like what you are seeing. Zone 1 is usually centrally located, which is associated with pancreaticoduodenal injuries or the major abdominal vascular injuries, like we are seeing in this young boy here. In zone 2 is usually in the flank regions, the perinephric regions, which is usually associated with injuries to the genitourinary system and even the colon. In zone 3, we have the pelvic region, which is frequently associated with pelvic fractures or the iliofemoral vascular injuries. And the patients, when they come to us, they may have these signs and symptoms. They may present with non-localizing abdominal flank pains. They may have upper leg pains. Some may even come bending because they're not able to walk upright. Some may have haemophilia, that is blood in urine. Some may come in shock because maybe they've lost a lot of blood which is in the retroperitoneal space. And some may have granulonephrosis, which is usually a late sign. The other area that we normally have bleeds is the head bleeds. and this can be superficial or deep. In superficial bleeds, usually the evidence of neurological changes are not so much. And they usually respond quickly to the treatment that is usually given. And this is very important because it will reduce the complications. And if the bleed is deep, that is when this bleed is intracranial. Most of them will present with the neurological signs and symptoms such as loss of consciousness, altered mental states, vomiting, severe anemia, generalized weakness, and they could be having headache. So when you see a baby has come to you reported that they're having dizziness, they've been vomiting, they have a headache, and they have generalized edema, and this patient is hemophilic, you should query that this patient is having intracranial bleed, and you take action immediately. So we look at the complication. We were just mentioning a bit some of the areas, but not all the areas. So some of the complications of hemophilia include the following. We have airway obstruction, usually because of the bleeds that can come into the neck or the pharyngeal bleeds. We have intracranial bleeds. We have intestinal obstruction. We have compartment syndrome. We have degenerative joint disease. We have chronic hepatitis. This patient usually gets plasma, concentrates and plasma. Like we were already told by our first presenter, some patients usually are given fresh frozen plasma, so they are prone to getting these conditions. So they also have a risk of getting HIV because of the use of the plasma that is derived from factor concentrates. Other complication is the psychosocial issues that this patient may come with because of the condition that they have. So to prevent this condition, we may not prevent it from not coming because it's hereditary and it's in the blood. Usually, this is to prevent any complication that this patient may get. So patient needs to be educated on how to prevent injuries. So we normally talk to them about the exercises they need to do. We normally tell them about the games they need to play, and we usually advocate for swimming for our patients. Also avoid intramuscular injections. Usually at times they go to the nearby clinic. So we usually tell them not to go for any IM injections because they're predisposing these muscles to bleed. Also avoidance of the non-steroidal anti-inflammatory drugs. These ones usually cause gastrointestinal bleeds. And also we advise them to get immunized against hepatitis B. There is also provision of counseling services which we have at our clinic. And also there's creation of patient support groups, which normally addresses the burden of mental health issues, which we already have a patient support group for our patients. There is also mass sensitization on identification and diagnosis of hemophilia to reduce morbidity and mortality due to the late presentation and to stop stigmatization from the community. So accelerating access to care for bleeding disorders across the country. And we have so many other treatment centers which we've been opening across the country, which is helping our patients. And we've been referring the patients who come from other areas to the nearby treatment centers to go for treatment. Otherwise, thank you so much for listening.
Thank you so much, Sister Marilyn, for that very educative session. We have learned the types, we have learned the severity, and we have seen how broad the bleeds can happen in hemophilia patients. Basically from head to toe, a hemophilia patient can present with bleeding within any system, from the CNS, that is the head, in the abdomen, the urinary tract, the muscles, of course, having the joints as the most common presentation, but also at birth. So next I'm going to present a very short presentation on the management. And now that we understand the background, the genetics behind it, the signs and symptoms. So these are the things you look out for, whether you're a clinician, whether you're a parent, whether you're a sister or a brother, whether it's you yourself, you've been having nosebleeds that you cannot quite tell where they're coming from. There are symptoms that you can tell. If you've had even a hematuria or urinary tract infections that led to bleeding, that's a reason for you to come for screening. And like we said, we are doing mass screening, so you're welcome to Kenyatta National Hospital for screening. So my presentation basically is on management of these bleeds with the modalities that we have at the moment. We are trying to reach the world-class level of management so far. So far, we use factor concentrates as the mainstay of treatment. So welcome to my presentation, the management of hemophilia. I'll just take you back a short trip from where the hemophilia treatment started. It has advanced a lot from the 1900s to where we are now. We started by using direct whole blood, and then we moved from that, and the technology improved, and the clinicians were able to extract plasma from this whole blood. And so they would get the fresh frozen plasma and infuse it in the patients who had bleeding tendencies, and it would help. However, for a short time. Then they went on ahead to extract the prior precipitate from the whole blood. And this is mostly used for hemophilia A patients because it has factor VIII concentrates only. And so it was useful. And around 1968 to around 1980s, they went on to produce or generate plasma-derived products, which are now commercially available as factor VIII concentrates. And then they moved on to further work on this plasma-derived factor concentrates by treating them. So they started working on the viral inactivation, because we know that blood products can come with infections such as hepatitis, HIV, and those were the concerns around that era. So they started viral inactivation around the 1990s to make it safer for our patients, because a number of them were getting these infections through the factor concentrates. So from the 1990s onwards, the technology improved, and we moved to recombinant factor concentrates. This was safer for our patients, so they generated both factor VIII and IX, and our patients were able to receive safe products for treatment of hemophilia. In the most recent technologies from around 2014 going on, they have further improved the technology of the factor concentrates to extended half-life products. These ones really, they last longer, they have a longer half-life in circulation. The patient requires less frequent infusions, have better adherence, higher trough levels of the factor concentrates in the body, better bleed protection, PK guided dose tailoring. So you can actually tailor the dose to a patient. So this was a very good technology, because we've also experienced using these products and they're quite good. So currently, more recently, actually from 2017 onwards, we've had non-factor therapies. This is what we call prophylaxis, and it's given subcutaneously. And it is very effective, especially for patients who have developed inhibitors towards factor concentrates because of the frequent exposure to the factor. So when their body has formed auto antibodies and is fighting the factor concentrates that you're giving to stop the bleeding, then we say that that patient has developed inhibitors. But now that we have technology such as the non-factor therapy, which is now the prophylaxis treatment we use, it has helped a lot in managing such patients so that they can still have a good quality of life. So, like I said, the advancement in treatment has helped a lot in viral inactivation. We have recombinant factor products. Prophylaxis is now a standard practice across the world. It has reduced the volume of how much factor you need to infuse a patient in order to stop a bleed. And it has, and also even the storage and the portability of these factors has greatly improved. So we're going to talk about the clotting factors. Basically, just to give you an overview of how you calculate. So the factors are measured in international units, and the clotting factors, the concentrate itself, you calculate per kg body weight of the patient. So if a patient is 20 kilos per kg, 20 kilos, it will be the international units multiplied by the weight. So this is just a pictorial example of some of the factor concentrates and how they look. This one is a Haemophilia B product. Not to market any product per se, but just to give us an overview of how they look. They come in those cases, and you can see how well they're packaged. The concentrate is in the middle itself, and then you have the adapter on the right. Yes, that is what you plug on top of the bottle. And on the left, you have the syringe, which comes with its own solvent. So everything is ready to use. You do not have to start looking for a syringe or a needle. They just come fully packaged and ready to use. And that's the modern technology I was talking about. So these are some of the doses that we get from the donors. They range from 250 international units all the way to 6,000 international units, depending on the brand or the manufacturers. And really, that's just another photo showing how they're packaged. So how to assemble the syringe and the needle. That's a photo that will show you once you have mixed the solvent, you just screw it onto, either you have a patient with an IV line or you're using the butterfly needle. You just need to screw it lightly and push the medication into the veins. So our medications are given intravenously. So those are other photos that are showing factor concentrates from different manufacturers. But really, this is what we have in the market, and this is what we receive. And we have also sensitized the majority of our patients on how to use them. So clotting factors, those calculations, really, we have one international, we'll start with factor 8, which is meant for treating hemophilia A patients. So 1 international unit per kg of factor 8 raises the plasma level by 2%. A minor dose will be 20 international units per kilo, while a major dose will be 40 international units per kg. And the half-life of factor 8 is 12 hours. For factor 9 patients, that's for hemophilia B patients, we have 1 international unit of factor 9 raises plasma level by 1%. So a minor dose, you will give 40 international units per kilo, whereas for a major dose, you give 80 international units per kilo. And the half-life of factor 9 is 8 to 24 hours, 18 to 24 hours. So there's minor bleeds. So we normally categorize our patients according to the presentation they come in. Some will come with minor bleeds, some will come with major bleeds. So for minor bleeds, you want to give really a lower dose because we also don't have so much of factor concentrates at our disposal. So this will just help us in knowing how to dose our patients. So for patients who come with early joint bleeds, soft tissue and muscle bleeds, nose and gum bleeds that do not respond to local measures, we give them a smaller percentage, which is about 40% correction. So for factor 8, you can start with 20 international units per kilo, Whereas for factor 9, you can start with 40 international units per kg. For major bleeds, what are major bleeds? Things that are life-threatening. So like advanced soft tissue and muscle bleeds. For example, if a patient is involved in a road traffic accident, you have the patient comes with a head and neck injury, or a patient presents to you with unexplained severe anemia, but they tell you they have melina, or they've been having frank hematochezia, frank stool with frank blood, then you definitely want to start on a higher dose. Before you do any imaging, before you start anywhere, first of all, infuse your factor at 100% correction. So for factor 8, you go at 40 international units per kg or higher. And factor 9, you do at 80 international units per kg. So the other treatment products, blood treatment products that we use in the event that you find yourself in a peripheral facility and you're not able to access the factor concentrates. What can you do before you refer your patient? You can use your blood products. You can use fresh frozen plasma. This is separated from whole blood and frozen. It mostly contains factor 9, but you can also give a patient whom you suspect has hemophilia and has not yet been diagnosed. So fresh frozen plasma is our to-go blood product. Then you can also, if you know the patient is hemophilia A, and you are able to access cryoprecipitate, you can give your cryoprecipitate. The other modality is whole blood. You can give whole blood where you don't have this where you don't have FFP or cryoprecipitate as blood products. Give whole blood. It has all the clotting factors, and that can be safe. At least it can buy time as a patient is being referred to a center with medication. So the other ideal treatment really is factor concentrates. So like we said, cryoprecipitate, this one is mostly and only used for factor 8 patients or hemophilia A patients who need factor 8. So it's a component prepared by throwing a unit of fresh frozen plasma and removing the cryosupernant. So 1 unit is a bag of cryoprecipitate. 1 unit in a bag of cryoprecipitate obtained from one donor. It contains the average of 100 international units of factor 8. It does not contain factor 9. That is important to note. Neither does it contain fibrinogen or von Willebrand factor. So the other modality of treatment is an antifibrinolytics. We have this ideally protects against the fibrinolysis by inhibiting conversion of plasminogen to plasmin. So in the event that you're forming a clot, you want to protect it to stop the bleeding from wherever the bleeding is happening. So it is extremely useful in mucosal bleeds, and we use it a lot for dental issues, oral issues, and it works very, very effectively. Of course, it's not a one-off dosing. You can give it for at least 3 to 5 days. Yes, and definitely that's the dosing, 25 milligrams per kg, 8 hourly, that's for adults, but for children, I know it's 15 milligrams per kilo. So I put this slide here specifically to highlight on the previous slide. When you have a patient with hematuria, kindly keep off antifibrinolytics because they cause obstruction and may lead to urine retention. So really the management of hematuria is bed rest. You want to hydrate the patient very, very well. Encourage them, if they're able to orally hydrate, let them drink enough fluids throughout the day. You can give an anti-inflammatory. You can also give prednisolone and give your factor concentrates at least 3 to 5 days. So this is just a summary of the treatment options for the different hemophilia patients, for hemophilia A patients and hemophilia B patients. So hemophilia A patients, you want to start with whole blood. You can give your fresh frozen plasma, your cryoprecipitate, desmopressin, especially for epistaxis, that the spray, you can give the nasal spray. You want to give the plasma or the factor concentrates. But of late, what is more available is the recombinant factor 8 concentrates. Then you may also use the antifibrinolytics where needed. Factor 9 deficiency, you have the whole blood, you have the FFPs, you have the plasma-derived factor 9 concentrates or the recombinant factor 9 concentrates, and your antifibrinolytics. So this is also just a summary of the factors you find in the different blood products. So in FFP, in platelets, in cryoprecipitate. Like we said, you'll only find you'll mostly find factor 8 in cryoprecipitate, whereas FFP will give you a majority of all other factors. So if you have a bleed and you do not know what diagnosis, they could even be a rare bleeder with a very rare bleeding condition like factor 10, give them fresh frozen plasma as you plan to either refer or screen for other clotting deficiencies. This is also a summary of the dosing of factor concentrates. So how do you do your factor replacement depending on the location and on the severity of the bleed? So as you can see, the columns, there's one for factor 8, there's one for factor 9, and the desired percentages and the doses required. So like for a joint muscle, or for a joint or a muscle and a soft tissue, the desired level is to give ideally 40 to 50% correction. So your international units will be at least 20 to 25 international units per kilo for that patient. That's a hemophilia A. But for hemophilia 9, it will be 40 to 50 because the ratio that will translate to plasma for hemophilia B patients will be 1:1. For example, let's go to iliopsoas, CNS, head and neck, throat. Those are major areas, and you know that's a big bleed. You want to target 80 to 100% correction of factor, meaning you want it to circulate as much. You want the levels to be as high as possible to stop the bleeding, so that you mitigate the possibility of mortality for this patient. So for factor 8, you target at least 40 to 50%, and for factor 9, you give 80 to 100 international units. Okay, next. So what are the other modalities of treatment that we have when we are managing our patients? We have prophylaxis. And like I mentioned earlier, we have better technology right now. So we have recombinant factors, which are easy to use, easy to self-administer, easy to store, and really easy to carry around. So we do practice prophylaxis with factor concentrates when they are available. Can be given once or twice a week over a period of months in order to suppress or prevent bleeds. So for people who basically you have a patient who always presents with GI bleeds that are severe, what you want to do is cover this patient. For example, it's a school-going child. You want to cover this patient with factor concentrates at least for a period of time, even though it's a dose a week, so that this child can concentrate in school, suppress the tendencies to bleed, and really improve the quality of life of this child. So the other prophylaxis type, which is a more recent technology and which is very useful at this moment, is the non-factor treatment. For example, what we have now is Hemlibra, which is a emicizumab, a monoclonal antibody that works by preventing bleeds in hemophilia A patients. So this one really is for hemophilia A patients, and it is not factor 8, but it works at the sites where factor 8 works, and so it stops bleeding. It reduces the tendencies to bleed, and our patients are really the small cohort that we were able to put on this prophylaxis have really had good outcomes. The majority of them had developed inhibitors. They were not responding to the common factor concentrates. They would frequently visit the clinic 3 to 4 times a week. You'd have these patients with the bleeds in the joints, in the gut, intracranial. The parents had no life. The children could not go to school. But once we started them on this prophylaxis, we have seen a great improvement. So this is other modalities that we use to treat inhibitor patients. So there's one that we commonly use. It's called FIBA, that is factor VIII bypassing agent. This one has several factors in it: factor 2, 7, 10, 9, 5. Really, it's a complex, but we use it sparingly because we spare it for factor VIII patients or 9 who have inhibitors. So it comes in as a last resort, but it's quite effective as well. It is also difficult to get it in the country, but we always request our donors to support us with it. So it works for patients with inhibitors. The other bypassing agent is Novo7. This is recombinant activated factor 7. It triggers the external pathway. So it works well for hemophilia B patients or factor 9 deficient patients when they have inhibitors. Thank you very much for listening to us. So we hope that you have learned. We'd like to go to the question and answer section. So maybe I will just go through them very, very quickly because we are remaining with about 15 minutes. So there's a question by Samson Mburu: what is the relationship between patients with cold or flu who present with nose bleeding? Is it a case of mild hemophilia? What is the management? So to Samson, I would say that it could be hemophilia. A majority of our patients whom we've seen present at our clinic do have nose bleeding when they have a flu, if that is the type of presentation for that child or for that adult, for that patient. And so screening is better than waiting it out. So you're welcome to visit any hemophilia treatment center across the country. We have boutique centers, Kenyatta National Hospital being one of them. Come, let us screen, and then we will decide whether the results will tell us whether that is hemophilia. The other question: do we have a national register for patients with hemophilia? Yes, we do. We have a national register, and we are currently still populating it because we have a mass sensitization going on. So Irene Olo, you're saying you've mentioned a risk of HIV transmission from plasma concentrates during treatment. Isn't it standard procedure for screening such transmissible diseases? I will welcome Margaret to answer that one.
Okay, our blood is usually screened very well, and any donated blood, before a person donates blood, it is usually tested for several things, including HIV. So it's usually very unlikely that a patient will get this infection from a blood transfusion, but there are chances that donated blood can contain HIV in less than one. One person in 2 million people. People usually donate blood and are screened carefully. However, if blood is donated by a patient who has just been infected by HIV within maybe 2 weeks before giving the blood, the test may not find the virus in the blood. This means there is a slight chance, a very slight chance, that this blood transfusion may infect this person.
Okay, thank you very much. The other question is, there's an anonymous attendee who's asking, factors are quite expensive. Those that are available for free are expired ones from donations. How safe are these? Sister Violet?
Okay. Before we were having expired drugs, but they were working. Since these are donations and they are very expensive, we couldn't manage to throw them away. We were still using them, and they worked well. So what happens with these drugs, the potency just goes down, but they are not harmful to the patients.
Okay, thank you so much. So you've heard that the old factors are not harmful to the patients. Another question is, in terms of recombinant factor concentrates administration, is it present and readily available? If not available, what's the availability of fresh frozen plasma and cryoprecipitate across the country? Sister Margaret? In terms of recombinant factor concentrate administration, is it present and readily available?
Currently, we don't have enough factor, but for the major bleeds, we are able to admit the patient for FFPs, which is readily available at our hospital, KNH.
Okay, there's another question from Farida Chakera, says, what percentage of hemophilia carriers show symptoms of bleeding? Maybe I could answer this. Not all carriers are bleeders. Some have normal factor levels, that is above 50%. Whereas those who have factor levels maybe at borderline 40% and below, then may present with tendencies of bleeding, such as bleeding of the gums during brushing their teeth, heavy menstrual cycles, having postpartum hemorrhage during delivery, or even antepartum hemorrhage during pregnancy. So they do not necessarily have to have symptoms. So it's a very small percentage of this, and we normally support them accordingly. The other question is, why is ileopsoas bleed corrected with a higher percentage as compared to others? Maybe I could answer this one. Ileopsoas is a major bleed. This is a muscle bleed that is happening retroperitoneally, meaning it's in the cavity of the abdomen, and it's a muscle that runs on the back, joining the spine. So this muscle runs all the way from the back into the pelvis, and a majority of our patients, when they have major bleeds, that is one of them. And so, like I said, for major bleeds, you want to give a higher percentage of factor concentrates, and that's how you manage it, because they can easily bleed out. They become severely anemic very fast. They can go into shock, and you can lose the patient. Beatrice Lungai, any arrangements to place capacity build testing laboratories in counties? I think I could also answer this. Yes, we are already capacity building laboratories across the counties. They are training more laboratory technicians to test and screen for hemophilia and other bleeding disorders. Through Kenya Haemophilia Association, there's also the donation of coagulation machines to capacity build, really, to enable other counties test for these patients even before they refer them. So you may not have the factor concentrates, but at least you can diagnose, and that is really helping. Maybe one or two more questions. So there's someone, Omondi, who's saying, is prophylactic non-factor treatment administered subcutaneously? That one I'll give Margaret. Is prophylactic non-factor treatment administered subcutaneously?
Yes, it's usually given subcutaneously, and it's also called Haemopphilia.
Yes, thank you so much for that. There's let me look for one more interesting question. What is the expected hemoglobin levels for a non-hemophilic patient? What is the expected hemoglobin levels for a non-hemophilic patient? Violet?
Okay, it depends on the patient and the way, if the patient is bleeding too much, the HB will go down. We get even those who have 3 and they are transfused. And when they are not bleeding, they have a normal HB like any other person.
Yes, thank you so much. That is true. When they are hemodynamically stable, meaning they're not bleeding from any site, their HB is normal. They're in good health, then you do not expect any bleeding from any site or the HB levels to be low. I hope this has been a very interactive session. I'm trying to look for one more question that would probably that I have not answered and would be beneficial to the listeners. There was a question that asked, please differentiate between the types of bleeds and complications. I think we mentioned that in Sister Margai's presentation. It was very well covered. Our presentations will be available with the KNH team. So if you need any of our presentations made available to you, kindly contact the research team. They will be able to assist you with them. So we are done basically, and we really thank you for logging in and listening to us. This has been a very wonderful session. We thank you. Thank you so much. Encourage any patient you see out there with bleeding tendencies to come to our facility for screening. It is ongoing yes, it's ongoing. I'm not sure of the dates, but I know up to 7th May, we will be screening for free. So if you have a patient, if you know a relative, if you yourself have bleeding issues, kindly go to any hemophilia treatment center. Kenyatta is one of them. Get yourself screened, and then let's help you or assist you from there. So remember, it is for free up to the 7th of May. Thank you for celebrating and commemorating World Haemophilia Day with us. God bless you.